Okay, welcome to all to this monthly conference, virtual conference that we have. Happy to have you all online. And today we will just continue with where we left off the previous conference in December with the discussion of soft tissue and bone and sometimes head and neck tumors as well. And the same theme and method of presentation applies. I will show you an H&E slide along with the history and show you the morphology, and then wait in anticipation for your differential diagnoses, your requests for immunos and comments, and just let the discussion flow from there. Ava will help me monitor the chat group because I've got to switch screens in order to see the chat group. But we managed the last time, so we should be able to do it. So let's kick off with this first case, which is, let's go back to low power, which is a oropharyngeal mass, or left tonsil mass, so more specifically in the tonsil. I'm just waiting for this to refocus. And you can see the mucosa of the tonsillar tissue, squamous line mucosa. That's not focusing too quickly, but I'll go to the areas that are better focused. And you can see the tumor here quite clearly, a hypercellular tumor with many of these vessels in the periphery. You can see they're showing the so-called staghorn vasculature, a nice clue that we use to identify neoplasms. Here it seems to be the same tumor with a somewhat myxoid stroma, and you can see the pattern of the tumor cells, almost lacy form here. Again, I'm just giving you descriptions as I see the slide, not deliberately intended to focus on a particular pathway of your thinking as well. Then I just want to go to the cellular areas, and I'll come back to these areas. But the cellular areas you can see here, very hypercellular. And I hope you can see this because it's quite dark, and I'm wondering whether the section was a little thick. But you can see these spindle cells, clearly hyperchromatic spindle cells, and this background of somewhat more round to epithelioid cells as well. Okay, so that's the hypercellular areas. And then I just want to go back to these areas that I promised you I would go to show you. You can see some of those epithelioid areas forming literally gland-like structures. Okay, it's gland-like structures. Here's the spindle cells, pointy tips, very little cytoplasm, a lot of overlapping nuclei, okay, and hyperchromatic. Now, this is the oropharynx. It's a tonsil, and I would imagine that the morphology is somewhat unusual, but let's hear and see what you think. Any thoughts on any investigations that you'd like, or any differentials you want to entertain? Here we go. There's the spindle areas and the more epithelioid areas adjacent to it. And I'll show you the high power of these spindle areas. Okay, hyperchromatic, a lot of overcrowding, overlapping nuclei. And just to remind you about this area, which is the same tumor cells, I believe, but in a much more edematous background. And I'm deliberately showing you this area. We can come back and talk about this area. But for diagnostic purposes, you could focus on these gland-like structures here, along with the spindled stroma, because I believe these are also those epithelioid areas, and they are just forming these gland-like structures. They're the same component of that. Okay, so we are good to go. Let's see. Sheena, squarely synovial sarcoma biphasic. Tom, vaguely adenosarcomatous, but let's go with biphasic synovial. Anastia, cytokeratins, okay, that's cooking. Andy, biphasic synovial. Admittedly, areas resemble myxoid liposarcas. I put for Omar, S100 pankeratin EMA. Okay, so let's go back to the slide. And again, forgive us because I've got to go through the two different screens in order to read your comments. And this is the slide comment. So let's give you the cytokeratin. And the cytokeratin is much more stronger in these glandular-like areas and these epithelioid areas. The EMA is also positive, focally positive. The CD34, I recall there was a CD34 there. Yes, that's negative. The S100, I should warn, can be patchily positive. And the early comments of biphasic synovial sarcoma are spot on and accurate. And here you can see the biphasic components with the spindled, hyperchromatic, overlapping nuclei. When you read the old books, they used to talk about these ice cream cones overlapping each other. I don't know if anybody talks about that these days, but in the comparison with fibroblasts and smooth muscle nuclei, which are more cigar-shaped, rounded edges, and then the pointy fibroblastic ones as well. So those are sort of differential diagnoses that you would think about. This is biphasic. The EMA keratin would highlight it, and if you have TLE1, which specificity is not that great, you could do that as well. But I would not make a primary diagnosis based purely on TLE1. I'd use the morphology, EMA keratin, noting that those are very focal and positive as well. But I would do the FISH analysis for SYT, which is SS18, which was positive in this. Now, the reason I was focusing on these more sort of, I wonder if it's truly myxoid or whether it is edematous. Nevertheless, if a needle core went through areas like this, you would not have synovial sarcoma as your first diagnosis. Like was pointed out, myxoid liposarcoma came into that differential. Omar has come up with the immunos and the FISH, so that's good. Myxoid liposarcoma would come up because of this sort of almost chicken wire type pattern. But remember, the chicken wire in myxoid liposarcoma is as a result of the vessels. These are tumor cells. So my choice of description here would be more sort of a laciform pattern. And this sort of pattern reminds me of a few tumors that come to mind, which I will share with you. Perineurioma comes to mind. You can see this pattern, the perineurioma. Schwannoma, this sort of laciform type variant of schwannoma. Those are two that come to mind immediately. And the third one, which I wanted to sort of briefly chat when I earlier said could be a pitfall, was solitary fibrous tumor. The myxoid areas of a solitary fibrous tumor can look like this. And CD34 would come in useful there, which was mentioned by one of the participants. Thank you. So CD34 and STAT6 would rule out SFT. So be careful of this and be aware of this. I saw a case a few years ago, young woman, mass in her groin, and the needle core kept going into areas like this. And we never really came up with synovial sarcoma in our morphological description, but when it was eventually resected, it was pretty obviously synovial sarcoma, and then confirmed with the appropriate FISH analysis as well. So that's why I'm showing you this area, just to keep that in mind. It's often predictable that the needle core biopsy could just get into these areas, and you don't necessarily see the more sort of diagnostic areas. The staghorn vasculature, which I alluded to earlier on, that's a nice feature for synovial as well. As you know, there are many other tumors that have that staghorn vasculature, including SFT, mesenchymal chondrosarcoma, endometrial stromal sarcoma, etc., etc. Any comments? Anything? Location is unique. Correct. No, it was primary as far as I know. So the head and neck surgeons had to deal with this along with the oncologists and radiation oncologists. But, the reason for showing you is because of the unusual site. So I believe they have been described in the literature, and there have been a handful of case reports of this occurring in the oropharynx. I like using the term oropharynx because in head and neck, you're thinking of the base of the tongue along with the tonsil and the palate. So that's an organ on its own in the head and neck. All right, are there any comments or questions? Okay, I don't see any there. let's go back to our list of tumors here and jumping into 7345. Here we go. I'll try and make this bigger. It doesn't help too much. Trying to give you a better picture. This is a tumor in the foot, and it's the medial surface of the foot. It's all soft tissue. It's about 11 centimeters in diameter and does involve bone as well, but it's primarily soft tissue. Okay, and here, oh, that's the bone there. This is all bone. Okay, so this pink area is all bone, and it's quite bloody as well. And you can see tumor cells invading here. So yeah, I'm going on high power just to show you these bony tubercules. Some of them are non-viable. Be careful that decalcification can remove the nuclei. So before deciding whether the tumor is viable or non-viable, just make sure you look at the fat cells, because that's a useful, helpful clue, I find. If the fat cells are viable, then it's more likely that the decal has disturbed the nuclear morphology and you're seeing just halos without osteocytes. Here you can see the tumor is quite viable. Little islands, nests, single cells, cords. Let's go back to the main mass. Here we go. And on high power again, just to show you the morphologies. Pretty decent morphology. Reasonable amount of cytoplasm, more than reasonable. Looks a little pinkish, eosinophilic. Nuclei, a little more epithelioid, sort of ovoid. And yeah, as we go down, you can see again, this might be a little thick, and I apologize, but the cytoplasm is eosinophilic and forming these cords and nests, background of collagenous stroma. Here again, just this trabecular pattern. Okay, so just to remind you, we're looking at medial surface of the foot, tumor that's 11 centimeters and does grow into the bone. And we saw that involving bone. So just if you missed that, you can see it involving the bone here. Okay, I think this was a amputation, as I recall. This specimen, this particular specimen, it's not the biopsy, it's the amputation specimen. Yeah, the morphology is not good here. There's a lot of crack artifacts. Let's move back to where we were. It's pretty decent morphology here. Okay, I haven't surveyed your chat box. Let's go back to chat box. Any thoughts? Nothing so far. Cords and nests. A lot of pink cells, epithelioid. Okay, Jan, Ewing-like. I like that, Ewing-like. Omar, can synovial sarcoma present as multiple lobules rather than in one single mass? Not quite sure what I mean. What you mean by multiple nodules? Separate primaries, satellite nodules? We can come back to that. Ewing-like, myepithelial comes to mind. Tom, Heba, melanoma. Yeah, you got a melanoma always. You know, you never discard melanoma in any context. You know, when I'm looking at biopsies, particularly soft tissue biopsies or bone biopsies, I'm always throwing in my melanoma markers. My screening melanoma, I may have mentioned this to you previously, but my screening markers are typically S100 SOX10 because of its role in nerve sheath tumors as well. But those are always in my differential diagnosis. So I like that, Heba. Sheena, translocation associated sarcoma. All right, I like that. Like B core. Okay, like B core. Let's go back to our tumor. Let's go back to our tumor. Let's go with, let's see, what are they? Ewing-like. So Ewing-like has to be a little better qualified because we may have spoken about this previously, because the atypical Ewings and the Ewing-like tumors have now been dissected, and you know, we have, like for example, the B core that's mentioned here was also sort of Ewing-like at some point, and then went on to atypical Ewings, and then with next-gen sequencing, we began to recognize that these were B core rearranged tumors and the sick ducts rearranged, etc., etc. So Ewing-like has to be. This is not a criticism, Jan. I'm just speaking out loud for people to sort of understand that Ewing-like does involve a group of other tumors, some of which have been characterized as well. So that's a good thought. And then translocation associated sarcoma, also good. Myepithelial comes to mind. Yes, pink cells, cords, nests, myepithelial markers for the melanoma, right? We have melanoma as well. And if you had melanoma, then you would do the S100. And S100 is also a marker for myepithelial cells, as you know. But in addition, for myepithelioma, you want epithelial, so keratin and EMA, and then the myo components. You want an actin or a calponin. I like both those markers for myepithelial. Desmond can be very focal, and H-cal-Desmond less often. So the muscle markers are negative, but we did say melanoma, so the S100 is positive. S100 is positive. So we'll go with that. And then Sheena has mentioned translocation-associated sarcoma. So yeah, I've given you now a little more information based on what you gave me. The epithelial markers are negative. The myeloid markers are negative for myepithelioma. But for melanoma, the S100 is positive. Okay? And now we're left with Heba and Sheena's suggestion of melanoma and translocation-associated sarcoma. Any other thoughts? Whilst you're thinking, we can just look at more morphology, cords and nests. This collagenous background may really be, some of the ligaments, or that may just be part of these. Yeah. Okay. Any other? Let's go back. Any other thoughts? Like Pico. All right. If you want the other melanoma markers, they are also positive. So take your pick. Okay. What are you going to do that, Heba? And Sheena is saying translocation-associated sarcoma. Oh, Tom, if S under diffuse and keratin deadening, epithelioid MPNST. Yeah, that's a good thought. It's a very good thought. Those are very pink cells in epithelioid MPNST. And remember, that goes by its own pathway. It's not the sort of NF1 or the H3K27ME3. That's going back to the chromatin remodeling proteins, ESS and SUS12, which are mutated in the usual conventional MPNST. Epithelioid is a different pathway. The only one, clue we have there is that INI1 SMARC B1 is lost in epithelioid MPNST. So that's the reason for the suggestion of consider INI1. So that would be that component. So Andy, was there an epiderm? No, this is all soft tissue, I'm afraid. There was no epidermal component. Let's go back to low power. It involved the foot, but there was no epidermal component for that definition if you're thinking about adnexal tumors as well. So melanocytic index, chase EWSR1 for clear cell sarcoma. I was waiting when that would come. Thank you, Sheena. Thank you, Tom. So this is, in fact, a clear cell sarcoma. And the S100 SOX10, and then, of course, the location. And remember, here there's some sort of vacuolation, and you may argue, is that clear or not? I don't know. But, more often than not, I see that in clear cell sarcoma, they look a little more pink rather than truly clear cell sarcoma. Dr. Enzinger described this, I don't know now, 40, 50 years ago as a soft tissue melanoma, malignant melanoma of soft parts. And that's a clue that the melanoma markers are going to be paused. And here, you may argue there's some clearing. I didn't see this first time around, but probably best that I did not see it, because it looks vacuolated and artifactual rather than really truly clear. So just a nice exercise to think about clear cell sarcoma, and in the context EWSR1, like was mentioned in the comment, is a good fish analysis to confer with your morphology and your immunohistochemistry. Multinucleated giant cells, like mentioned here, this sort of wreath-like giant cells is is a useful clue and can be helpful, not to be confused with the osteoclast-like giant cells or the Teuton-type giant cells. So I did not see any, and I'm just looking here now because I don't remember whether there were any giant cells. But the nests and cords are useful, very nested. And remember, these can sometimes be even spindled. You can get spindle cells as well. And immunos and your fish analysis will help you and bail you out. All right, let's see if there are any questions or other further comments. Remember and recall, we talked a few weeks or months ago, and I don't keep notes or recordings of these things, but we did talk about the group of what Sheena mentioned earlier, the translocation-associated sarcomas and the EWSR1 and CREB group. So remember, EWSR1 belongs to the family of FET, F-E-T, which is FUS, EWSR1, and TRAF15, and that fuses with the CREB group or CREB family, of which this is one of the clear cell sarcoma. So EWSR1 and CREB. I think it was, I don't know what the fusion is, so I shouldn't say what the fusion was in this tumor. But the CREB family comprises CREB1, ATF, and CREM, CREM. And we talked about the different tumors that belong to that. And there was a nice question from one of the group who said, do I have any review papers that goes through all of the 9 or 10 tumors that belong to this FET CREB fusion related sarcomas? I'm talking about primary pulmonary myxoid sarcoma, GNET, gastrointestinal neuroectodermal tumor, and a whole slew, hyalinizing clear cell carcinoma, intracranial myxoid mesenchymal tumor, etc., etc. I've not come across, and I'm still looking for a good review. Maybe one of you may want to write one of those. It's a good review to put out there. Seminars in diagnostic pathology will accept something like that. So it's good to bring them all together and crystallize them. There hasn't been no new tumors added to that group, so maybe a review will be nice. So anybody can pick that up and run with that. Any other questions or comments? Everybody's quiet, which means you want to move on to the next case. And if I can, I cannot open it on this field. There we go. All right, something 9001. There we go. Let's have a go at this one. All right, so this is a pelvic mass. Patient is 42 years old, and this is also 11 centimeters, so it's pretty large pelvic mass, 42. This section looks much better. Those dark, thick sections are difficult to deal with on digitized images, but I guess this serves a purpose and it's convenient, and it's nice to have these. But here you can immediately see lots of vessels, okay? So the stroma here, you may say on low power looks myxoid, but I hasten to add that I think it's more sort of edematous. I think this is water. It's fluid, edema, right? I don't think it's myxoid. And the reason I'm happy to say that is because if you look at the background, it's white, and this is also white. Similar to that synovial sarcoma, I think it's more edematous rather than truly myxoid. Now, to confirm that, you would probably have to do mesenchymal myxoid markers like Alcian blue at certain particular pHs, which I used to do when I was growing up in South Africa. I used to do the Alcian blue at different pHs. The lab used to perform. We used to use that for mesothelioma, really, to demonstrate Alcian blue with and without hyaluronidase, to demonstrate hyaluronic acid in mesothelioma. You don't need that these days because you've got a panel of immunohistochemistry. Now, whilst I've been, jabbering along, you've been looking at the morphology here, right? You can see the vessels, the edematous stroma, and then within the stroma, there's some of these sort of strands of cells, which look like blood vessels. But as we go closer, you can see these are ovoid, maybe a little spindled, and there's a little collagenous background. And you can see how this is splayed by the water, the edema, all right? And that's what gives it that sort of almost myxoid appearance. And then the vessels, not to be left out, are important in that there's quite a few of them. So it's innumerable vessels, and you can see some of these cells here, cords and strands, bland looking, no mitoses. I'm happy to share that with you. I know it's difficult looking at the screen and determining whether it's ugly or not. These look pretty bland, and here you can see them around that vessel, between the vessels, in the somewhat edematous stroma. Okay, and then here we move on. Oh yeah, here we go. So you have more of a solid looking stroma between the vessels. Yeah, just to illustrate that point. Here you can see the spindled ovoid cells, a very collagenous background, right? You can all see this wiry collagen. So collagenous background, lots of vessels, and these spindled ovoid cells, and then this edema separating these stromal cells even more, just adding to the confusion, really. Let's see, what are people thinking? All right, so we have epithelial angiomyolipoma. Angiomyolipoma, as you know, I think you want to say epithelioid angiomyolipoma. That's referring to the morphology of large pink cells, and angiomyolipoma would belong to the PICOMA group. So for that, you'd want the PICOMA markers. Michael, extracellular myxoid chondrosarcoma. I'm moving backwards. Okay, Tom is there. Deep angiomyxoma. I like that, Jan. That's a good aggressive angiomyxoma. Ali. So remember, the WHO does not call it aggressive angiomyxoma. Those are in parentheses nowadays. It's usually deep, open parenthesis, aggressive, close parenthesis, angiomyxoma. Okay, just FYI, because they realize that even though they invade deeply into the pelvis, it's not really that aggressive. So they call them deep angiomyxoma. That's a very good thought. In truth, some of these areas that we see here, I hope you can still see this field. In truth, some of these areas would pass with that, and you get blood vessels as well. It's usually very hypocellular. When you look at it, it's so bland, and you can sometimes get bands of smooth muscle traversing the tumor. So that's a good thought. But remember also, your oncologist or your surgeon would tell you that this is deeply infiltrative. It's not the superficial angiomyxoma that you see in the skin of the vulva. So this is going far deeper than that. And if you have the HMG-A2 fish, that's helpful. High moiety group A2, that's helpful to confirm that diagnosis. I've kept Ali's angiomyolipoma there at the back. So deep angiomyxoma, I would go back just to say, and I did not say this to you, I'm going back to the slide, but this was just a section. This is not the entire section, it was part of it. Radiologically, this was well circumscribed. So being well circumscribed is critical and important to whether it's a deep angiomyxoma, because those are ill-defined and deeply infiltrative. Just going back to this power so we can talk and look at the slide. And so just based on that, I probably would not pursue that any further, like with fish for HMG-A2. But that's a good thought. It's a very good thought. I failed to give you the radiology and the gross, that this was well circumscribed. It was 10, 11 centimeters, but well circumscribed. Okay, so my apology, but I'm glad you mentioned the deep aggressive angiomyxoma. Omar wants an SMA, S100, ERG. He's not telling us why he wants that. So a little cryptic, but there is some SMA immunoreactive, but not that much. S100 is negative. ERG, of course, is going to highlight the endothelial cells of the blood vessels. So the stromal cells are S100 negative. And I think for discussion purposes, Omar, let's say that the SMA is negative for now. It's an important thought that you bring into the conversation, a myoid component, but I won't say more. Let the others have a go as well, right? Mohammed, myopericytoma. That's also a very good thought. Myopericytoma. So that belongs to the perivascular myoid tumors, that group, including glomus tumor and myofibroma, etc., etc. Not going to talk any more about that. But again, typically this sort of concentricity made you think of myopericytoma, which is great, and those should be actin positive. So Omar's actin will help you in that regard for a myoid differentiation, and they're much more cellular. The myopericytomas are much more cellular with this onion skinning around these vessels as well. I just want to address Ali's angiomyolipoma. There we go, angiomyolipoma. So I did not do the picoma markers in, like you would do with muscle with the picoma. So the melanocytic. So actin was asked for, and I sort of downplayed that a little bit. But the HMB45 melanae were negative, and that was not done here. But was I would add that they were negative. I'm coming down now to the bottom three, which are coming in, and I love your differentials and your thoughts. So thank you for all of that, because it's what makes a discussion active. Okay, Abu Baker, angiomyofibroblastoma. Okay, you want the truth of it? You are spot on, Abu Baker. That's correct. AFH, I see in deep soft tissue, like in the lung, you can see it sometimes. Those typically, again, have that central sort of histiocyte-like proliferation of epithelioid cells. The periphery has this lymphoid cuff. So those are useful, helpful clues. But thank you for that. And AFH belongs to that group of FET Krebs group. So because that has ATF and EWSR1, just to add to that, I didn't mention that in that group. So it also belongs to that part of the group. Heba, angiofibroma. Angiofibroma, you have to qualify. Yeah, you can get soft tissue angiofibroma, and then you can get the cellular angiofibroma. So I'm hoping you're thinking of the cellular angiofibroma, because then this would fit into that lower GYN tract mesenchymal tumor. That's my coined term. I like to use that because it reminds me that these tumors like cellular angiofibroma, angiomyofibroblastoma, and myofibroblastoma, and angiomyxoma occur in the lower female genital tract. And I'm saying female with some caution because this is a male. So that's the reason that this is, did I say male? No, I beg your pardon. This is a female. She's 42. So these can occur in males as well. And I've seen them in the upper thigh, the groin area, paratesticular area in males, and then in women around the vulva, and this is pelvic. So this is deep in the pelvis as well. And they can go up. I've seen some being around the rectum as well. I remember that very clearly because I sent that to Dr. Fletcher during a Christmas season about 5, 6, 7 years ago. But this is angiomyofibroblastoma. Now, why am I confident of that? Because these epithelioid and spindle cells around these blood vessels, these guys here, these are Desmond positive. That's a useful clue to that. Now, Desmond's also positive in myofibroblastoma. Okay, so you have to keep that in mind as well, because myofibroblastoma comes into that differential, but myofibroblastoma does not have these thick wall vessels that you're seeing, and these large vessels, the varying, variable size of vessels. Myofibroblastoma, they're usually small, not the hyalinized ones of cellular angiofibroma, but you do get the small capillary type vessels. They're much more cellular. They can be edematous as well, but those of you guys who look at the breast will know this much better than me. Myofibroblastoma, pretty much a little more uniform, but a whole slew of morphologies that can occur in myofibroblastoma. The ER is also useful, but ER is not discriminatory between those tumors because these are lower genital tract mesenchymal tumors, which are ER positive, but it does help you identify it. Even in males, you get ER positive. Think about the breast line, okay? So the breast line starting from the axilla, down the nipples, anterior abdominal wall, down to the vulva, groin, paratesticular area, sometimes even on the buttocks. So anywhere along that area, you can get these tumors. So always think about them in that context. What else? Desmond. So myofibroblastoma, the way I think about that, which is much more uniform rather than these varying size of vessels, are spindled, ovoid, much more uniform. Desmond and CD34 positive. And RB1, of course, is lost. So that's another useful clue in that regard. Cellular angiofibroma, also CD34 positive, RB1 loss as well, but no Desmond to my knowledge. So you have to play around with these markers, keep them in your mind when you approach these tumors. no two tumors look alike, and you generally have to use the markers to good effect. Here, these characteristic epithelioid cells around vessels with Desmond immunoreactivity is a very nice, useful feature, and I like that, along with the varied size of vasculature and, of course, ER positive. RB1 was intact in this because, as I said, RB1, this is not one of the RB1 lost tumors. All right. So nice, interesting, benign, bland-looking tumor. Yeah, Cal Desmond, I'm not aware of that, Ali. So not in these tumors. I don't know whether I know Desmond is positive. I'm not sure of H-Cal Desmond positive. I like using H-Cal Desmond for uterine smooth muscle tumors. It's a good heavy chain myosin marker. So I didn't do it here. Here I found nice Desmond immunoreactivity, and I found that the ER was positive. That was enough for me to go with that. And RB1, of course, was retained. And along with that morphology, well-circumscribed tumor, felt very confident with that morphological interpretation. Any questions, comments? Whilst I look for the next one, I'm just looking at our time. Okay, so we have another 20 minutes to have a little bit more fun. 9813. Let's go back to the slide. 9813. There we go. Okay, let's take a look at this one. Why are the slides so dark on this group of slides? I don't know. 24, male. So this is a recurrent neck mass. I'm going to try and find you some nice areas to help you. So it's pretty similar. It's mesenchymal tumor, and unfortunately this guy had many recurrences, and this is one of those recurrences which I put a slide into this seminar. So here I'm just taking you on high power just to show you, because this is all the same morphology. Excuse me, a lot of crack artifact there, so we'll pass that by. Let's try and stay with the morphology, and that section seems to be the best. I think this is the best. It's a sort of thinnish. You can see this sort of small capillaries in the background, and ovoid and spindle cells. Okay, ovoid and spindle cells, and you can see the collagen component, sort of almost crisscrossed, in the background. And this does have some myxoid matrix as well. Now you can see the myxoid here. It's this gray, bluish material, which is what I like to see to label myxoid material. Pretty similar throughout. This is what the tumor looked like. He had about 3-4 recurrences, and this is what it always looked like. All right. So collagen, wiry, little small bands. Don't take my description. I don't like sort of uttering descriptions which put you into a wrong pathway, but some of them do remind me of certain morphologies. So as I see it, you're not quite rope-like, but there's some collagen there as well. And here it's looking a little more spindled. Let's see if anybody's coming up with any thoughts so far. Okay, sorry. There was a extraskeletal myxoid chondrosarcoma in the last case as well. I apologize. I did not address that, but I see it's come back up here now again. All right. So Sheena looks like DPhil myxoid liposarcoma, Abdullah extraskeletal myxoid chondrosarcoma, and Omar wants a DDIT. So DDIT, as you know, I wish I could remember what DDIT stands for. It's DNA damage. I know the DD. I forget what the IT is, but that's a gene. It's rearranged from chromosome 12 in myxoid liposarcomas. So I can see the thinking here is myxoid liposarcomas. Just for terminology, Sheena, just the myxoid liposarcomas, or as the WHO accepts it these days, there's a low grade, right, which we still regard as low grade, the classic chicken wire hypocellular with lipoblast around the vessels, and truly hypocellular as low grade. And then when the round cells get in, then it becomes high grade. Round cell percentage is always a controversy, whether it's 5 or 25, but now the WHO calls them low-grade myxoid liposarcomas and then high-grade myxoid liposarcomas with the round cells. The old term was round cell liposarcoma. So they put it all into one group as a myxoid liposarcoma because they share the same fusion, one without round cells, one with round cells. Round cells, herals, high-grade. So that's simple. So we don't use D-differentiated in that. Just D-diff is reserved for the well-diff liposarcomas. All right, that's the only context where we use D-diff in liposarcomas. Okay, so just helping along there with some terminology. So D-diff is negative, Omar. I'm sorry, I did not do it in this, and I don't know if it was done in the past, but it was not done, but I would assume it's negative. When you hear the answer, you'll understand why I'm saying that. So I don't think it's a myxoid liposarcoma. So extraskeletal myxoid chondrosarcoma, typically in the extremities, deep soft tissue, lobulated, again also very less cellular. The classic ones, the low-grade classic ones, with a laciform pattern. Some people talk about holding hands. The cells are holding hands. They've used that, which is a nice way of describing that laciform pattern with this mesenchymal myxoid matrix. Those, as you know, EWSR1, NR4A3 rearranged. That's also the FET group, but not the CRIB. NR4A3 does not belong to CRIB, but EWSR1 or FUS in that regard. Myxofibrosarcoma, Ali, those typically have to be nicely lobulated with a lot of myxoid material, which you have here. You have a lot of myxoid material. And atypia. Atypia is an important component of myxofibrosarcoma. Even in the low-grade ones, you want to see atypia and a lobulated pattern. The vasculature in myxofibrosarcomas tend to be sort of more like arcades or curvy linear, right? So they sort of curve like a snake going across the screen. I don't have another way of, but they're much bigger than these guys. These guys are small, sort of nondescript capillary. Yeah, spindle cell lipoma does have to come into that differential HEBA because the cellular varieties, and again, you're going to be asking yourself the question, is this a truly ropey collagen or not? And it's not easy to be sure about that or not. So RB1 is lost in spindle cell lipomas, and you can get some S100 immunoreactivity and CD34 as well. So this tumor I will add is S100 and CD34 positive. So both those. I've showed you the collagen in the stroma. I'm trying to find some sort of collagen around vessels. I cannot find any collagen around vessel, but this is a difficult case. It's you've all addressed it with the usual suspects, which I applaud. Here again, you may say, wow, this is looking a little more like myxoid liposarcoma, but doesn't have the chicken wire vascularity. Round ovoid cells doesn't have, but CD34 S100 was positive. Now, any thoughts in a young male in the neck with this stroma that's spindle ovoid cell, with the stroma that has this collagen matrix? And I'm looking for perivascular collagen as well. And that's what the books talk about, and I'm trying to help the conversation along there as well. But I cannot find that. But that's a usual, what was in the neck, soft tissue in the neck. Myepithelial carcinoma, yeah, you have to rule out. That would require, like we discussed earlier, epithelial markers and myeloid markers, my favorite being SMA and calponin, epithelial, EMA, and keratin. This is keratin negative, EMA negative, but CD34 pos, S100 negative. Superficial spindle cell tumor, CD34 superficial spindle cell tumor. Yeah, I know what you're referring to, the PRDM rearranged tumors. Those usually have giant cells and pleomorphism without mitoses. It's a good thought, Mohammed. I didn't think of that. Myxoid DFSP, yes, of course. And if I hasten to add that the S100 is positive, there was a series of 5 cases recently I think these were from the group in Australia talking about DFSP having S100 positivity and seem to be more associated with fibrosarcomatous transformation. So I can't use that as an excuse, Ali. That's a good thought. And myxoid stroma removes that storiform pattern. So the myxoid DFSP, that would be a good. Myofibroblastoma, yes. That has to come into that conversation as well. CD34, S100 is going to be a little odd there for myofibroblastoma. ER, I like doing ER for myofibroblastoma. Neck, again, I don't want to say never, but I don't think I've seen one in the neck. It starts off in the axilla and then curves down the nipple. I've seen them in the axilla. Of course, the breast people will tell you that. I've seen anterior abdominal wall, then going down to sort of vulvar paratesticular areas. EHE, epithelioid hemangioendothelioma, vascular markers. Remember, those are much more epithelioid with a lot more cytoplasm. And the stroma, yes, is a myxo-hyaline stroma. So that would, be understandably why you're considering that. Mohan, the solitary fibrous, yes, they can be myxoid as well. But S100 is a little odd for that. So CD34 going on to STAT6 will help in that regard. S100, CD34 neurofibroma. Yeah, you're right. You're spot on right. N-track rearranged. Right, there you go. Okay, Mohammed. Spot on. Yes, thank you. That's what this was. This had to be sequenced and proved to be I think it was the recurrence that was sequenced. I don't know what the primary was called, and N-track fusions. I think it was sequenced and the N-track rearrangement was demonstrated. So this group, as you all know, is no longer sort of an emerging, it's well recognized. Yeah, N-track rearranged spindle cell neoplasm. And there's a whole group of, so the N in this instance is neurotropin, the T is tyrosinase, and R is receptor, K is kinase, tyrosine receptor kinase. And there's a whole slew of genes that are involved in this. Not N-track, I would say, was probably the seminal one. I may be wrong. And then, ALK can do that as well, ALK rearrangements. And then things like ROS can do that as well, ROS. RET can do that. MET can do that, EGFR, etc., etc. So there's good reviews out there when you Google them. And those are all the genes involved in the tyrosine receptor kinase rearranged tumors. So the way to recognize it is spindle cells with this round ovoid with collagenous stroma, perivascular hyalinization, and then a combination of CD34 and S100 will help you in that direction. That's why I kept emphasizing that part. So morphological clues, yeah, the collagen, the stromal collagen, and the perivascular hyalinization. But believe me, they do have a heterogeneous morphology, and you have to just be thinking about it with the monotony, like Sheena mentioned earlier on. When she said translocation associated tumors, they tend to have this monotonous cytology, uniform monotonous cytology. And if you think about diffusion related tumors, they typically do have that kind of pattern, which makes you think about these fusion related tumors without stains. Well, if you got the N-track rearranged, on next gen sequencing, if you have that luxury, then you'd get your answer. But I think in a young person, when this thing recurred, it was then subjected to next generation sequencing, NGS, and that was picked up. You can fish the N-track as well. There's 3 genes there. I think N-track 3 is the most common one for these tumors. Is N-track 1 and 2, and then 3. Remember the ETV6 N-track fusions. That's the seminal one that you'd all remember that from secretory carcinoma of the breast, secretory carcinoma of the salivary gland, and then of course this mesoblastic nephroma and so on, right? What are we getting then? Any morphological clues? Yeah, okay. So a good example of that, where you go through a wide differential diagnosis, and the uniformity should help you subject it to sequencing. But CD34, S100, and then the collagen. I just saw this vessel here now. There's a little bit of collagen around here. I just saw that now. I just was looking for that helpful clue. And most of these are called tumors, but you can get a range of morphologies, right? Those that have a morphologically bland cytology, all the way through those that have, low-grade sarcoma cytology. And it's pretty much a case with many of these fusion-related tumors. They rely on morphology to determine the biological behavior. So good news, guys, we're still in a job. The oncologist cannot stick in needles and send it for next-gen sequencing and treat their patients. Okay. And of course, in this instance, oh, look, this thing is invading muscle, right? So you've got skeletal muscle embedded right here as well in the neck. With those recurrences, I'm not surprised. So the other thing you all know this, but you get the NTRK inhibitors, the tyrosine kinase genes inhibitors, which are useful to shrink these tumors down. Yeah, prognosis depends on the morphology, but if you make a diagnosis here early and get them onto the NTRK inhibitors, you can shrink it down before surgery. And this guy, for some reason, just recurred many times, even though the morphology, you can see, I've shown you many fields. Have you ever seen the mitosis? No. Any pleomorphism? No. No necrosis. But this thing just kept coming back and back. So it's hard to predict, I mean, this we'd call neoplasm or tumor, right? NTRK rearranged neoplasm or tumor. I don't think anybody would sort of, call this sarcoma right off the bat. Some people may say low-grade sarcoma, a little more cellular, but yeah, the morphology, would put it into a particular grade. All right. Any other questions? I didn't look there. Okay, what's the prognosis? Yeah, that's dependent on the morphology, Sheena. But there's a whole lot of papers out there with the morphologies and the different fusions, and you can Google those and read about them. NTRK rearranged mesenchymal tumors. All right, last case. Do we have time, Ava? 1:55.
Yes, I think so.
Okay, let's do one more case. Ava says we can do one more case. I might leave you with it. Excuse me. I bet you didn't expect this. This is the wall of the aorta, and I'm trying to figure out why there was an aneurysmal dilatation, and the cardiothoracic surgeons or vascular surgeons went in to replace this aneurysm, and it wasn't my case. I'll admit to that. It was sent to us from our colleagues who do more of the cardiac pathology. So here you go, just to show you a nice morphology wall of the media. You can see these wavy collagens and elastic fibers. A little bit of myxoid degeneration here. You can see that in nice bluish, right? So be careful, like I was saying earlier. Don't confuse water edema for myxoid. This is myxoid matrix. This is a mucoid degeneration myxoid, which probably is the reason why it's an aneurysmal dilatation, right? With myxoid, we don't know the reason for that, and Marfan's is, as you know, the inherited gene that this is associated with. This is not Marfan's to my knowledge, but this was just mucoid or myxoid degeneration of the aortic wall. Now, this was sent to us. Why? Because of this, right? Because of this. Here we go. So this is in the adventitia. Let's just get you orientated well, right? There's the media, there's the intima, not much thickening, just myxoid. Yeah, it's a little myxoid material thickening there as well. And then there's the adventitia. You can all appreciate cirrhosis of the adventitia. And then here you have these cells, sort of pinkish, largish cells, pink and large, and then here's more of them here. I don't want to use the word gland-like. I don't want to confuse you, but you can see these somewhat uniform-looking cells, little cords and nests, pink cytoplasm. Okay, these cells, those and these are probably the same. Here, these are embedded in the adventitia, and you can see these cords and nests of cells. All right, there you go, trickling along. Right, low power, very hard to see, but as we go down, you can see more and more of them here. There we go. You can see these cells here. All right. Okay, that's pretty much it. So nothing about the aorta, but except the adventitia, which has this sort of bland-looking proliferation of epithelioid pink cells. Okay, looks vascular, Omar. Looks, oh, thank you, Antoinette. You're welcome. Yeah, time is up. So how about we leave this for the next time? All right, I don't want to hold you up, nor do I want to hold you up for your next obligations. Let's leave this for the next time, and with Ava's permission, we can, stop there. And just to remind us, Ava, when's the next meeting? I'm trying to page through my calendar here. I think it's 18. Would that be correct, Ava? 18 February, right? Ava checking there as well. Okay, so I see some interesting, yeah. Thank you very much to you all for participation. I look forward to seeing you all again in February. I think it's February 18. I'm actually quite sure about February 18. And Ava will confirm that for us. So thank you. See you next time. Ava, are you there? Yeah, it is fun, Andy. That's why we do it. Yeah. All right. Thank you, guys.